All right, let's get right into it. Today we're talking about a skill that can, and I mean this literally, save a life: the assessment of an immobile patient. For any of us in rehab, therapists, nurses, doctors, mastering this is just non negotiable. So, we're going to break down a really practical guide to protecting your patients, focusing on their skin and their circulatory health. And that really is the key question, isn't it? What dangers are hiding in plain sight? Because the biggest threats, well, they aren't always the most obvious. They don't come with loud alarms or super clear symptoms right at the start. No, they tend to develop quietly, often tucked away under the sheets, which makes your assessment skills so incredibly vital. And here they are, the two big ones: pressure ulcers and deep vein thrombosis, DVT. These are the twin threats we have to be so vigilant about. Their real danger is just how quiet and fast they can be. What might look like a small red spot one day can become a serious, life-altering wound seemingly overnight. It happens that fast. So, where do we even begin? Well, the very first step is identification. We've got to know right away which patients need our most focused attention right from the moment they're in our care. So let's build that high-risk patient profile. Okay, let's really zero in on these three groups. First, stroke survivors. They often have a double whammy, right? They've got motor issues that keep them from shifting position, and sensory issues that mean they might not even feel that dangerous pressure building up. The same logic applies to our patients with spinal cord injuries. And really, anyone who's had a long stay in the ICU is at extreme risk just from the sheer amount of time they've spent immobile. Okay, so once we know who is at risk, the next question is, where do we look? This next part is all about the hands-on physical exam, really mapping out the body's most vulnerable spots. Look at these areas here. They aren't random. They're all what we call bony prominences, basically places where the bone is super close to the skin without a lot of natural padding. So if your patient is lying on their back, you're looking at the back of the head, or the occiput, the sacrum, and especially the heels. Heels are huge. If they're on their side, that pressure point shifts over to the hip, the greater trochanthers. And for a patient who's sitting a lot, the risk moves right to their sit bones, or the ischial tuberosities. This is your critical inspection checklist, every single time.
So, let's say you've done your scan and you've found something, an area of concern. Now what? It's really not enough to just jot down red spot on sacrum in the chart. We need a common language to describe what we're seeing, and that brings us to staging.
The answer is a standardized system. And the guidelines from the National Pressure Ulcer Advisory Panel, the NPUAP, are pretty much the gold standard. This system gives all of us a shared vocabulary to grade these ulcers, from a stage 1, which might just be a red area that doesn't turn white when you press it, all the way to unstageable wounds where you can't even see how deep it goes. And this isn't just about paperwork. Clear staging makes sure every single person on the care team knows how severe the issue is and, importantly, what the right treatment plan should be. Moving on, a really good assessment goes way beyond just looking for ulcers. We have to learn how to decode the more subtle clues that the skin and the circulatory system are giving us. You can see here, it's a night and day difference between healthy skin and skin that's sending out warning signals. So let's break these down. Erythema, it's more than just simple redness. It's what we call non-blanchable, meaning when you press on it, it stays red. Maceration, that's when the skin gets all soft and white and fragile because it's been exposed to moisture for too long. And you always have to be on the lookout for those classic signs of infection. Is the area warm? Is there any swelling? Any drainage? Catching these things early is absolutely everything. Okay, now let's shift our focus a little further down the body, because a patient's legs can tell you a whole story about their circulation. We just need to know how to read it. Let's look at 3 really critical clues. First, and this is a big one, any new one-sided swelling, especially in the calf, is a major red flag for a DVT until you can prove it's not. That needs immediate action. Second, look for chronic signs, like a lack of hair on the lower legs. That can be a sign of poor circulation over time. And third, notice any major color changes. Is one leg unusually pale, or does it have a dusky, kind of bluish tint? All of these things point to circulation problems that you just can't ignore. And this all brings us to our final, and maybe the most important point of all. Every one of these assessment skills, from identifying the right patients, to mapping pressure points, to decoding the skin, it all funnels down to one crucial goal. This right here, this is the why behind everything we've talked about. Early detection isn't just about good clinical practice, it's about preventing a catastrophe.
An untreated pressure ulcer can lead to sepsis. A missed DVT can travel to the lungs and become a fatal pulmonary embolism. So our assessment isn't just about the skin, it's about stopping these life-threatening problems before they can even start.
You should never, ever underestimate the power of your own eyes and your own hands. Fancy technology and special beds are great, but nothing, absolutely nothing replaces a consistent, thorough, head-to-toe skin and circulatory assessment. That systematic scan you do, when it's done regularly and documented accurately, is the single most powerful tool you have in your arsenal.
And that's really the bottom line, isn't it? This isn't some abstract theory from a textbook. It's a tool you can use on your very next shift to protect your most vulnerable patients. It's a fundamental part of what we do. So as you go about your work, ask yourself this simple question: whose skin will you save today?